Okay, welcome back, future nurses. This will be my last material for this semester. And as my constant reminder, make sure you read your Brunner book. The cardiovascular disease is the leading cause of death in the United States for men and women of all racial and ethnic groups. The term ACS, or acute coronary syndrome, is used to describe the area of clinical presentations that range from unstable angina to acute MI. The continuum from angina to MI or myocardial infarction will cause symptoms that are due to imbalance between myocardial oxygen demand and myocardial oxygen supply. So, the most common cause of cardiovascular disease in the United States is atherosclerosis or your coronary atherosclerosis, which is defined as an abnormal accumulation of lipids or fatty substances and fibrous tissue in the lining of arterial blood vessel. These substances will block, okay, it will block and narrow the coronary vessels in a way that it will reduce the blood flow to the myocardium. Atherosclerosis is also responsible for cerebral vascular disease, peripheral vascular disease, and some manifestations of renal disease. Atherosclerosis involves a repetition inflammatory response to the injury of the arterial wall and subsequent alteration in the structural and biochemical properties of the arterial walls. The key point that you need to know here by now is coronary artery disease is one manifestation of atherosclerosis, okay? CAD is also prevalent in an estimated of 15.4 million people over the age of 20 and is the most common cause of heart disease.
So we know that atherosclerosis is the main contributor to coronary artery disease, and in the coronary arteries, atherosclerosis will cause buildup of these fatty cholesterol-filled plaques. Like so, you can see me drawing them in here, and they're occurring all over the coronary arteries. So what they do is they sort of obstruct blood flow down the length of the coronary arteries and through all the branches of the coronary arteries because they're just these big bulges of fat that are in the way. So how do they develop? What exactly is this process of atherosclerosis? Well, let me show you what this looks like in a snapshot before we actually look at the mechanisms. So I'll take this piece of coronary artery here, let's say this piece right there, and we'll blow that up. So if we look at that, and when it's nice and healthy, right, it's going to look like this. So here's our healthy blood vessel, nothing built up inside, and so you can see blood is going to flow through this way, right? And this here is a cross section of the artery. So, as far as we can tell, blood can flow smoothly and nicely through this blood vessel, no obstruction, everything looks good. But when you start getting atherosclerosis happening, things can get a little bit different. So, when you start getting atherosclerosis happening, your coronary artery might start to look something like this. And so immediately, I mean, we can see that there's a pretty big difference between the first vessel here, the nice clean one, and the second vessel here, the atherosclerotic, sort of fatty plaque vessel here. All this yellow stuff is some gross fatty plaque that's been deposited into the vessel wall. And if we look at the cross section here, we can see that it's really doing a number on the amount of blood that's able to flow through this vessel, right? And so if we're blood here in red, we can't actually get through this vessel quite as much as we could through here. Look how much room we had in this one. And so this is why, because of all this buildup, this is why we're going to get downstream symptoms. How exactly does this happen? Well, let's redraw our own arteries so we can go through it step by step. So here's our blood vessel there, and now I'm drawing the three layers of the wall of the blood vessels. And on the very inside of the blood vessel, as part of this pink layer here, we have a single layer of cells called the endothelium. So let me just draw out the endothelium here. And although it's just a single layer of cells thick, the endothelium has a lot of really important roles. One of its really important jobs is to act as a barrier. And it acts as a barrier between stuff that's in the blood and the rest of the blood vessel wall. So stuff can't just pass through and get into the rest of the blood vessel wall. And this barrier function will become pretty relevant in a minute. You'll just have to take my word for it for now. And another really important job that the endothelium has is to secrete proteins onto its surface that prevent clotting, that keeps blood flowing nice and smoothly. So those are two of its major jobs. It has a couple more, but those are the ones that are relevant in atherosclerosis. All right, so you remember that big fatty vessel from before. Well, how do we get from this, our nice clean blood vessel, how do we get from this to that? Well, let's take a look. Well, the first thing that has to happen is that there has to be some irritant present, something in the blood that's going to predispose this atherosclerosis to happen. So, what are some irritants? Well, things like too many lipids. So specifically fats and cholesterol, LDL cholesterol, the bad cholesterol. And let's actually put some of this cholesterol in the blood vessel so we can just see it really clearly. And I'll just label it LDL, LDLC actually, so you know that this is cholesterol, LDLC. Another irritant, probably the worst one, is toxins from cigarette smoking. So we'll put some toxins in the blood from cigarette smoking. We'll do them in gray here. And another major one is just hypertension, high blood pressure. So we'll try to show that pathologically high blood pressure here by these arrows. High blood pressure. And this means high blood pressure. And I'll actually write hypertension here because I just want to make it clear that it's the chronic exposure to high blood pressure. It's not just, high blood pressure every once in a while. So that's our first step, to have an irritant present. And our second step is to actually have damage to the endothelium by the irritant. And so our barrier now is broken down. It started to break down. So that's step 2. That's actual damage of the endothelium. And in step 3, regardless of whatever damaged the endothelium, I mean, if it was toxins or if it was the cholesterol or if it was the high blood pressure, regardless of what actually damaged the endothelium, what happens next is that the cholesterol will jump in there and start to collect under the damaged endothelium. So let me actually clear away some of this because we're going to focus on the cholesterol now. So this is cholesterol, and it's going to sort of settle in here. It's going to think to itself, hey, that looks pretty comfy. That looks like a cozy place to be. So I'm going to just jump in there. And of course, these are coming from inside the blood, right? They're not just sort of multiplying. They're floating around in the blood. And then when they come across this damaged endothelium, they're going to join their friends. And when they build up to this sort of flattened extent here, they're known as a fatty streak. So one thing that happens to the cholesterol when they get inside the wall of the blood vessel there is that they start to get oxidized. They sort of change a little bit. And when they change, when they get oxidized, that sends a signal to the immune system, to our body's immune system. And that signal will bring around these cells of the immune system called monocytes. So they'll sort of show up almost like police. So here's a monocyte here, and I'll draw it in white to remind you that it's a white blood cell. And this monocyte doesn't really like that the cholesterol is starting to collect in the blood vessel walls. So the monocyte will actually chase in after the cholesterol to try to break up the little party that they're having. And so I'll actually draw what happens next down in this next bit of the blood vessel down here, just so we can keep in mind all of the past events. So you may have noticed that I drew this white blood cell to look like a Pac-Man sort of thing, eating up this cholesterol, because that's essentially what it does. Once it gets into the endothelium, it converts into something called a macrophage. Macro meaning big, and phage meaning to eat. So it's really this big eater I mean, its job here is to devour that LDL cholesterol that's collected in the endothelium. Unfortunately, things don't go as planned for our macrophage because what ends up happening is it starts to gorge itself. The macrophage eats so much cholesterol that it just sort of becomes too full of these yellow cholesterol drops, and it sort of dies off. But it's full of cholesterol, and someone a long time ago looked down a microscope and thought that these dead macrophages filled with cholesterol looked like foam, like sea foam that you see at the beach. So these dead macrophages filled with cholesterol are now called foam cells. So let's catch our list up. And remember, these foam cells were actually white blood cells. So when they die, they release these signals that sort of call in reinforcements. And I'm going to use that to remind you that atherosclerosis is primarily an inflammatory disease. It's an inflammatory condition. And so when these foam cells release their cytokines, their signals, they call in reinforcements, and the whole process sort of proceeds in this vicious cycle, as you'll see. And don't forget that LDL is also still being deposited into the wall from the bloodstream. And as part of this inflammation, more and more endothelial cells get damaged. So I'll move our drawing down even further so we can look at the next sort of development. And so you can see this mountain of cholesterol and foam cells, dead macrophages that are filled with cholesterol. You can see this mountain just keep on building and keep on building and bulging out into the middle of the blood vessel. And so by now things are just way out of control, right? And these guys in here, this is the smooth muscle part of the artery, by the way. So this is the smooth muscle layer. These guys start to take notice, these smooth muscle cells. So what ends up happening is that you get smooth muscle cells that sort of migrate out of the smooth muscle layer, and they sort of migrate. I hope you can see this. I'll draw them a bit thicker. They start to migrate out of the smooth muscle layer and into the fatty plaque here, right? Because they can sort of sense that something's just not quite right. And what they start to do is they really want the plaque covered up because they don't want the thrombogenic. Remember, thrombogenic means clot forming. They don't want the thrombogenic plaque to be exposed to the blood. So what they start to do is they start to secrete a fibrous cap. They sort of spit out this collagen and elastin protein cap that covers up, right? So I'm drawing it in purple, that covers up this plaque and shields it from the bloodstream. And that's called a fibrous cap. And they also do something else. The smooth muscle also do something else. So you remember these foam cells that died in here? Well, when they release their signals after they die, they induce the smooth muscle into depositing calcium into the plaque. So I'll draw that in. I'll draw in these little calcium crystals now. So you can see it's just starting to look like a mess in here. There's just all sorts of stuff going on. So again, this is really not something you want to have happening in your body. And so just by looking at this, what can we say is happening to the blood vessel? Well, I mean, we can see this huge bulge. We can see that the plaque is obviously bulging into the blood vessel, and it's probably going to restrict the flow of blood that can get through here. So that's one thing that atherosclerosis is doing. It's occluding, it's blocking off the arteries. The second thing is, well, look at this calcium. I mean, if there's one thing we know about calcium, and that is that it's really tough, it's really hard. And so this by the smooth muscle laying down calcium, that's one of the ways that atherosclerosis makes your arteries really hard. And that's actually part of the name. Atherosclerosis actually means hardening of your arteries. But I think in terms of coronary artery disease, the biggest reason that atherosclerosis is bad is because it can cause complete blockage of the artery. And that blockage of the artery can happen because sometimes this plaque, this fatty plaque, it can rupture. And when it ruptures, all this thrombogenic plaque material gets exposed to the blood. And when it gets exposed to the blood, it starts to form this really big blood clot in the middle of your artery, in the middle of one of your coronary arteries. So let's just draw that in here. Let's just draw this big blood clot. Pretend that this has been ruptured and this yellow thrombogenic material has been exposed, and this big blood clot's going to form. By the way, I'm originally from Jamaica, and blood clot is a bad word in Jamaica, so I apologize to any of my Jamaicans who are watching this. So this big clot could form, and it could totally block off the blood vessel. And when that happens, no blood can get through, right? So this is really the biggest reason that we don't want atherosclerosis to be happening in our coronary arteries, because you can see that we've blocked off the blood flow, and if blood isn't allowed to get past this clot and get to the piece of the heart that it's supposed to be serving within about 20 minutes, then you get irreversible damage and death of that piece of heart muscle. So for example, what we drew was this little piece of artery here, right? In blue. So if a atherosclerotic plaque and a clot developed right there, as it has in our vessel here, then that would be really, really, really bad because, all the blood for this whole part of the heart is coming from this upstream vessel. So without getting blood flow through this vessel for about 20 minutes, if this clot sort of persists for about 20 minutes, all of this heart muscle would start to die off. So that would be a massive heart attack. And actually, let me just clarify. So we say heart attack, but in medicine, we refer to a heart attack as a myocardial infarct or an MI. So myocardial just refers to heart muscle, cardia for heart, and myo for muscle. So heart muscle. An infarct means death of tissue due to lack of oxygen from lack of blood. So a myocardial infarct is death of heart muscle due to lack of oxygen. So here we've had a myocardial infarct due to this big plaque that developed here.
So, do you still remember your coronary circulation or your coronary arteries way back in your ANP? So, let's revisit that role of your coronary arteries. So, what do they do? What's the function of your coronary arteries? So, basically, they're called coronary arteries for a reason. They are supplied outside. Okay, it's called corona, so it's kind of wrapping around your heart, specifically on your myocardium. It supplies the heart muscle or your myocardium with blood, oxygen, and nutrients. Okay, they are outside, like they're in the epicardium and bifurcates down to your subendocardial layer, meaning so it gives off this, it feeds your myocardium with blood, oxygen, and nutrients. So just a little bit of anatomical terms in here. When we say anterior, it means front. Obviously, posterior is back, lateral is side, and inferior means lower or inferior wall or the lowest part. Okay. Now, let's talk about these two main coronary arteries that we can see in this picture. So, the coronary circulation has two main coronary arteries, your left and the right. Let's start with your right coronary artery or RCA. So the RCA supplies the blood to the right ventricle and the right atrium. Some well, SA node, not some, 55% of people it with the SA node, AV nodes, and bundle of His. Yep, we're going back to electrical conduction because the RCA feeds the upper portion of the electrical conduction system of the heart. RCA also divides into smaller branches, the right posterior descending artery, as you can see in this picture, and there's another one, it doesn't say in here, but it's the acute marginal artery. Basically, what it does is the RCA supplies the blood to the inferior wall, okay? Inferior wall of the LV, the posterior wall of the LV, and also this patients, okay, this patients will with a right coronary artery occlusion will experience bradycardia, AV block, RV failure, right ventricular failure, and what we call an inferior or posterior wall, MI, or myocardial infarction. Left main. The left main coronary artery, okay, it supplies blood to the left side of the heart muscle or your myocardium, meaning your left ventricle and your left atrium. Okay, so your left main coronary artery, your LMCA, it bifurcates into two, your LAD and your left circumflex. Okay, your left main coronary artery, guys, it is the most significant of all. Okay, because when the left mainstem disease, it puts the LV in jeopardy, and this can cause the sudden death. Okay, so let's talk about your LAD or your left anterior wall descending. So your left anterior descending artery, it branches off to the left coronary artery and supplies blood to the front of the left side of the heart and the anterior and lateral wall of the left ventricle as well. So it feeds the right bundle branch as well. So not just the left side, not just the left side of the heart, but the bundle branches right and portions of the left side or portions of the left bundle branch. So occlusion of the LAD will place the patient at risk for heart failure and bundle branch blocks. This is what we call a patient who's going to have anterior wall myocardial infarction, If there's no supply of blood or nutrients or oxygen to the myocardium, it's going to be called myocardial infarction, or specifically for an LAD disease or occlusion and anterior wall MI. These kinds of patients are called the widowmaker. Okay, it makes them widowed because of the bundle branches that's blocked. The circumflex artery, on the other hand, it branches off to the left coronary artery, and it encircles the heart muscle or myocardium. So basically, this artery supplies the blood to the lateral side of the heart and the back of the heart. So any occlusion of the left circumflex artery, or now we call the lateral wall MI, will experience AV blocks, bundle branches, but among the three, the circumflex is actually the most benign part or kind of myocardial infarction. So that is a review of your RCA. I don't think it's a. I think it's good to know like where the coronary arteries are. Just kind of have an idea about this picture. Why? Because on your next slide, I'm gonna make you watch a video. Okay? I just talked to you a little background about coronary atherosclerosis, but the more that you understand, the process of developing or the development of atherosclerosis, the more you'll get it. So I found this really nice YouTube video of the pathophysiology. Give yourself 14 minutes. I think it's a really good, video or a material for understanding coronary atherosclerosis. I love this video. So you guys watch it and learn from it. Now you've learned which artery is blocked. You know that coronary artery disease will produce symptoms and complications according to the location and degree of narrowing of the arterial lumen or any thrombus formation, obstruction of the blood flow to the myocardium. Okay, so the clinical manifestation of coronary artery disease, or let me just say CAD, these are virtually silent. Okay. Normally, you don't really feel it unless the arteries is approximately 40% blocked by plaque. Okay. This impediment to the blood flow is usually progressive and causing an inadequate blood supply that deprives the cardiac muscle cells of oxygen needed for their survival. This condition is now called myocardial ischemia. Okay. So remember, ischemia develops when there is an imbalance between supply and demand of oxygen rich blood to the heart tissue, resulting in insufficient oxygen to meet the demands of the myocardial tissue. Infarction or cell death occurs when the imbalance is severe or prolonged, which causes irreversible damage. So the primary patient's complaint is chest pain, okay? So it's also called an angina pectoris. Angina is classified into two categories, which will be explained later. Now, angina pectoris refers to the chest pain, as I keep on saying, and it's brought about by a myocardial ischemia and is usually caused by significant coronary atherosclerosis. So, if the decrease in blood supply is great enough, or it has been there for a long duration, or both irreversible damage and death um, may be the result of it. So over time, irreversibly damaged myocardium undergoes degeneration, and is replaced by scar tissue, causing various degrees of myocardial dysfunction. So, significant myocardial damage may result in persistently low cardiac output and heart failure because remember, if there's already scar tissue, there's already myocardial dysfunction, think about the patient's contraction, okay? There will be not enough. It's not nourished well. There's no oxygen. The myocardial cells are dying or degenerated. So it may not be functioning and contracting well. That's why it will persist and or it will be persistently giving you low cardiac output and probably heart failure, wherein the heart cannot support the body's needs for blood anymore. So, a decrease in blood supply from CAD may cause the heart to abruptly stop beating. So, this is now called your sudden cardiac death. All right. So, the most common manifestation of myocardial ischemia is the onset of chest pain, you know, some complaints of epigastric pain and pain that radiates to the jaw or left arm. People who are, older or have a history of diabetes or heart failure may report short of breath. Many women who have found to have atypical, not normal symptoms like chest pain, they could have, complaints of indigestion, nausea, palpitation, numbness, and occipital pain. So not necessarily that, patients with chest pain, you think of CAD, and not because patient has just sore throat, you think of patient having a flu. I remember when I had a patient, she's a female. Like I said, women have found to have atypical symptoms. She came in for for a sore throat. And we were like, oh, maybe you just have the flu, or maybe you have GABS. GABS is group A beta hemolytic streptococcus. So maybe just have some pneumonia, thinking about respiratory issue. So basically, if it's sore throat, would you think of doing EKG? Some, probably not, but in ICU, because it's a routine thing, you don't know what's going on, just sore throat, came in with some blood pressure changes or vital signs are low, stuff like that. So we would not have known it, that something's happening in in her cardiac status, when we saw that that patient is actually having a heart attack as we speak. So not necessarily patients complain of chest pain, but that sore throat was her chief complaint, in not really having a chest pain. But when we check her cardiac, the ECG, it showed like a massive MI, which is really, really weird for us, but it did happen. So just don't stick on chest pain, oh, heart attack. So think of something else. Think outside the box, not just sore throat. Think of flu. No. So yeah, those are specific clinical manifestations that you need to know and understand. So again, as a recap, when you think of risk factors, we think of classify, or they're classified as a modifiable or non-modifiable. And when we talk about modifiable risk factors, you know for a fact that these are amenable to intervention, something that we can change, while non-modifiable factors are inherent risk factors that are not amenable to interventions or something we can't change. So in your book, page 752, chart 27-1 gives you the list of the risk factors for coronary artery disease. And examples of your non modifiable risk factors are the following. It says here family history of CAD, anybody with a first degree relative with a cardiovascular disease at 55 years of age or younger for men, and at 65 years of age or younger for women. Increasing age more than 45 years for men and more than 55 for women. Gender, men will develop CAD at an early age than women. Cardiovascular events in women occur in average of 10 years later in life than they do in men. The male to female ratio is approximately 3 to 2 or 3 to 2. Women tend to have a higher incidence of complications from cardiovascular disease and higher mortality. We tend to not recognize the symptoms. Women tend to not recognize the symptoms of CAD as early as men, and they wait longer to report their symptoms and seek medical assistance. That's why they have a higher mortality. Menopause is now recognized as a milestone in the aging process, during which risk factors tend to accumulate. So the thing with the postmenopausal women, they are 3 times more likely to have clinical symptoms of CAD than women of the same age who are premenopausal. So this evidence suggests that estrogen may be cardioprotective. Okay. Race. We have higher incidence of heart disease in African Americans, Mexican Americans, Native Hawaiians, and Asian Americans, and they have higher prevalence compared to Caucasians. Next thing, examples of their modifiable risk factors. We do have here hyperlipidemia, cigarette smoking, tobacco use, hypertension, diabetes, metabolic syndrome, obesity, physical inactivity. Let's start with the best one. I say the best one because this is really a diabetes type 1 will definitely increase the risk for heart disease even when the blood sugars are well controlled. Okay, the risk greatly increase obviously when the blood sugar is not well controlled. Patient or anybody with an elevated low density lipoprotein, or again your LDL or your bad cholesterol, it's a known risk factor and actually the primary target of cholesterol lowering therapy. So you want to check on that every time they need labs. Next, people at the highest risk for having a cardiac event are those with known CAD, or as I mentioned earlier, their diabetes, also other vascular disease like peripheral artery disease, abdominal aortic aneurysm, or carotid artery disease. The likelihood of having cardiac events is affected by factors such as the age, gender, systolic blood pressure, smoking history, level of the total cholesterol, and level of your high density lipoprotein, HDL, or also known as your good cholesterol. All right. In addition, a cluster of metabolic abnormalities such as metabolic syndrome has emerged as a major risk factor for cardiovascular disease. A diagnosis of the syndrome includes three of the following conditions. Your book actually says that insulin resistance, meaning a fasting plasma glucose of 100 mg per DL or an abnormal glucose tolerance test. Central obesity, wherein waist circumference is more than 35 for female and more than 40 in males. Dyslipidemia, where triglycerides is more than 150 milligram per DL, and HDL or high density lipoprotein or your good cholesterol is less than 50 in females and less than 40 in males. Again, blood pressure, which is consistently greater than 130 over 85. Pro-inflammatory states such as high levels of C-reactive protein or CRP. You also want to check for the prothrombotic state or high fibrinogen level. And lastly, um, these risk factors, the way to prevent this is you want to maintain a healthy lifestyle, diet, and modern exercise schedule, as these are obviously the important factors for controlling the risk for heart disease. So there are four modifiable risk factors that I mentioned earlier. The cholesterol abnormalities, use of tobacco, high blood pressure, hypertension, and diabetes. So among all those risk factors, these are the four established risk factors for coronary artery disease and needs more attention in promoting healthy lifestyle for patients with CAD. So let's start with cholesterol control. Your LDL or a fasting lipid profile should demonstrate the following values. The LDL cholesterol should be less than 100 milligram per DL or deciliter, or less than 70 milligram for very high risk patients. As we keep on mentioning, your LDL or bad cholesterol is the target of current therapy because of its strong association with advancing CAD. Next is the total cholesterol level. This is also a clear predictor of coronary events, and you want this less than 200 milligram per DL. HDL cholesterol or good cholesterol or high density lipoprotein cholesterol has to be greater than 40 milligram per DL for males and greater than 50 milligram per DL for females. It's known as good cholesterol because it transports all other lipoproteins such as LDL to the liver where they can be degraded and excreted. Triglycerides or trigs should be less than 150 milligram per DL. Triglyceride is made up of fatty acid and is transported through the body, through the blood by a lipoprotein. And any elevated trigs or triglyceride levels can be caused by obesity, physical inactivity, excessive alcohol intake, high carb diet, diabetes, kidney disease, and certain medications such as your oral contraceptives and corticosteroids. Number two, prevention, dietary measures. So just like your hypertension, you wanted a diet low in saturated fat. You also want a high in soluble fiber, a TLC diet or therapeutic lifestyle changes diet, which is found in table 27-1 on page 75. That's important. Please read that. Mediterranean diet also promotes vegetables and fish, and restricted red meat is also reported to reduce mortality from cardiovascular disease. Next, prevention, physical activity. Regular moderate physical activity increases HDL levels, which is your good cholesterol, and reduces your trigs or triglyceride levels, thereby decreasing the incidence of coronary events and reducing overall mortality. Okay? Or risk for mortality. You want to engage the patient in moderate intensity aerobic activity for at least 150 minutes per week, or vigorous intensity aerobic activity for at least 75 minutes per week. That's the goal for most adults according to CDC. Meds. Lipid lowering agents can reduce CAD mortality in patients with elevated lipid levels and is or any patients at risk for normal life lipid levels. So statins, fibric acids, bile acid sequestrants, cholesterol absorption inhibitors, and omega-3 acid ethyl esters. These are examples of our lipid lowering agents. Such medications are found in table 27-2 on page 756. You guys may want to check that out. It's also seen in the next slide. Next, cessation of tobacco use. So why is tobacco or cigarette smoking so bad? So I'm sure everybody knows, or maybe some of you knows that the smoking can cause the development of severity of CAD in three ways. One, nicotinic acid in tobacco triggers the risk of catecholamines, which can raise the heart rate and blood pressure. Nicotinic acid can also cause the coronary arteries to constrict, therefore leading to increased risk for CAD and sudden cardiac death. So, nicotinic acid, vasoconstrictor. That's one. Two, smoking can increase oxidation of LDL or blood cholesterol bad cholesterol, sorry, that damages the vascular endothelium, thereby increasing platelet adhesion and leads to a higher probability of thrombus formation. So, one, vasoconstrictor, two, increases platelet aggregation, thereby causing clot, and three, caused about by the oxidation of LDL. Okay. Three, inhalation of smoke increases the blood carbon monoxide level and decreases the supply of oxygen to the myocardium. So remember the balance between myocardial oxygen and supply and demand. So those are things that you need to do. Therefore, you want to encourage a patient to stop tobacco use, stop, not limit, but stop tobacco use through any means possible. Managing hypertension and controlling diabetes. I'm not going to go through all that because you have already learned this in the past few weeks. So these are CAD prevention and things that you need to know for patients who are at risk or who have coronary artery disease. So if diet alone cannot normalize serum cholesterol levels, remember your cholesterol should be less than 200 milligram per DL, then medications are ordered, and this has a synergistic effect with the prescribed diet and also control your cholesterol levels. Lipid lowering medications can reduce CAD or coronary artery disease mortality in patients with elevated lipid levels and also with at risk patients with or high risk patients with normal lipid levels. So the following are the various types of lipid-lowering agents, and they affect the lipid components somewhat differently. So you would see in table 27-2, page 756 are commonly prescribed medications that affect lipoprotein metabolism, therapeutic effects on different lipid panels like cholesterol, LDL, HDLs, and trigs or triglycerides will increase or decrease depending on the medication. So we have one in here. The first one is your 3-hydroxy 3-methylglutaryl coenzyme A or HMG CoA, or what we normally or commonly known as your statins. Examples are atorvastatin or your Lipitor and the simvastatin or Zocor. So you might probably have been giving this in your clinical time. We also have the fibric acids or the fibrates. Medications are fenofibrate or your Tricor and femfibrozil, which are Lopid. So these are examples of their fibric acids. The other one is the bile acid sequestrants or resins, and medications such as cholecystyramine or questran, and cholesterol absorption inhibitors like ezetimibe and Orzetia as the brand name. We also have the omega-3 acid ethyl esters, also known as your fish oil capsules. So let's go ahead and start talking about angina pectoris or angina, however you want to say it, angina or angina pectoris. Angina pectoris is a clinical syndrome usually characterized by episodes or paroxysms of pain or pressure in the anterior chest. The cause is insufficient coronary blood flow resulting in a decreased oxygen supply when there is increased myocardial demand for oxygen in response to physical exertion or emotional stress. In other words, the need for oxygen exceeds the need for the supply. Physical exertion can precipitate an attack by increasing myocardial oxygen demand, such as one, exposure to cold places. They can cause vasoconstriction, and it can also elevate the blood pressure, which then increases oxygen demand in the heart. Two, eating a heavy meal. So when you eat a lot of stuff, okay, a large meal increases the blood flow to the mesenteric area for digestion, thereby reducing the blood supply available to the heart muscle. Okay, this also gives you an idea why you feel tired or sleepy right after eating a large meal, because all or most of the blood has been focusing on the mesenteric area and less blood supply on the brain, hence like feeling tired or feeling sleepy. Next, stress or any emotion provoking situation can cause the release of catecholamines, and you know that catecholamines can increase blood pressure and heart rate, and again will increase the workload of the heart. Now these are the different types of angina or angina, and you can see the way it shows in the picture. So the types of angina is seen in page 757, chart 27-2. It shows the different types. Like I said, let's start with a stable angina. It's a chest pain or discomfort that is associated with physical activity. Okay, so it is typically linked to it's a fixed plaque formation. So what kind of symptoms do they have? So this patient will have chest pain or any kind of pain, and alleviated with rest or medications. And the medication that we give for angina is the drug of choice is nitrates or the nitroglycerin. These are potent vasodilator. They dilate the coronary arteries, thereby it improves the oxygen rich blood flow to the heart and then prevents and stops the chest pain. Okay, those are stable angina. Next, we have the unstable angina. It refers to the chest pain that can occur at rest. Of the two types of angina, unstable angina is the most concerning, and it is identified as the initial phase of acute coronary syndrome and can be a precursor to myocardial infarction. It should be treated as an emergency, guys, because this unstable angina, it's usually prolonged and may not be relieved with medication. So in addition to nitroglycerin, these patients may require medication such as morphine. Obviously, supplemental oxygen is probably necessary because of the demand of oxygen to the myocardial cells that's been damaged. So both stable and unstable angina, they're both temporary and it can be reversible. Now, we also have the intractable or what we call refractory angina. It may mean severe incapacitating chest pain. Okay, a variation of an unstable angina is variant or Prince Metals angina. Okay, wherein there's a blockage of blood flow in the coronary artery that causes the coronary artery to have the spasm. Okay, and there is no black, or I'm sorry, there is no plaque formation. However, the coronary seems to be spastic. um, but commonly after sclerotic change, it typically occurs at rest and in clusters. So interestingly, with Prince metals angina, it normally occurs at night between midnight and 8 a.m. with chest pain at rest and reversible ST segment elevation.